Okay, here's one of my favorite chapters coming up. It's entitled, very narrow title, LPs in febrile infants 29 to 60 days old. So we're talking about one test, LPs in the second month of life. That's it. This whole talk is about LPs in the second month of life. And the reason we're talking about that is because the incidence of meningitis has fallen substantially. And now people are looking at doing the number needed to puncture it, one in 200 cases, 1 in 300 cases, 1 in 400 cases. So you're going to puncture 400 kids, and look for meningitis in those cases? Probably not. And so there's some new stuff coming down the pike. Now the first month of life is kind of like, there's nothing really remarkable about in the literature or about the first month of life. You get the blood culture, you get the lumbar puncture, you culture that, you get the blood culture, you give them a shot of some antibiotics, cefuroxime, clafurin, or something to that effect. In the hospital they go, or they get transferred. That's it. Maybe some fluids as well. So first month of life is kind of a no-brainer for kids who have fever. Either they sick or not sick looking, it doesn't really matter. Just treat them, kind of thing. We don't have enough ability to discriminate who's high risk and low risk in that age group. The second month of life is kind of a different story, though. And the literature we're talking about is really right on point for this. We talked about this last year, but there are some couple of papers that came out that really are making a difference, and should make a difference, I think, in your practice. The whole issue is meningitis. And, if you have pneumonia, you're allowed to wait a day to make that diagnosis, or 2 days, and that's going to make probably a big deal difference, maybe a little. If you have a positive blood culture, you can probably make that diagnosis a day or two later and probably make no difference. And a UTI. Why do they call it UTI? When you think of a UTI, you're thinking of a woman who has pain when she pees and is peeing very frequently and may have some blood in her urine. She has no fever. She's otherwise well. She's probably had this a bunch of times in the past. It's a simple cystitis, in some cases hemorrhagic cystitis. Okay, got it. We're going to give the antibiotic and off they go. Do those people have fevers? No, absolutely not. What do we call it when you have a urinary infection and a fever? We call it pyelonephritis. So why do we keep on calling the UTIs in kids? I think it kind of demeans the real diagnosis here. The diagnosis is pyelonephritis in a febrile 102, 103 kid. That's what we're talking about. And I don't know why nobody talks about that. You read all of these articles, and it's about UTI. And where was the equal sign? UTI equal pyelonephritis in these febrile kids. You just don't see it. So I think you got to call a spade here. In this case, a UTI, a pyelonephritis here. So the bottom line is we've got to get on it and make the diagnosis of meningitis, because we can't wait 1 or 2 days to make a diagnosis. We're going to make it on the first visit to you. And we know that there's neurologic sequelae, and the longer you wait, the more they're likely to get bad. And when you cure the person, they still may have substantial neurologic sequelae for the rest of their life. So the clock is running in these cases. What we're going to focus on is well-appearing children. Well-appearing children. Now that's kind of like what is a well-appearing child? Well, you know it when you see it. But, however, think of this. Well-appearing child is here. Critical child is here. You know what a critical child looks like. They're limp. They're mottled. They got no circulation. They're having some difficulty breathing because they're acidotic. This one's obvious. This one is not obvious, but they got a fever. And somewhere along this slope, this child is coming in. And is that child well-appearing? And it also depends on how many kids you've seen. If you're in a rural area, you might not have seen a lot of kids in the second month of life who have a fever who otherwise look well. And that's really exactly what we're talking about here. And so the question is, how do we approach these cases? The question first is, how is a low-risk infant between the ages of 29 days and 60 days to find. Now, you remember in the old days they had the Boston criteria and the Rochester criteria and the Philadelphia criteria? They all came out with criteria to identify low-risk patients who had fever, who were in this age range, 1, 2, 3 months. And the weirdest part about it is, in their initial protocols of finding out who was the kid that was at high risk, they all required that you do a lumbar puncture. Well, once you've done the lumbar puncture, everything's been done. So it was like, that never made any sense. So then they took their protocols and modified them, quote unquote, modified them, took that lumbar puncture out and basically said, can we use a protocol to define who is low risk versus not low risk in terms of serious illness? And even there, the definitions are a little weird. Serious bacterial illness, you're looking at all the papers on pediatric fever. Serious bacterial illness, what is that? It's bacteremia, meningitis, or pyelonephritis, otherwise known as a UTI. One of those three. What do they call invasive bacterial illness? Meningitis or bacteremia? They kick out pyelonephritis. I have no idea. Now, I'm sure that there's some smart pediatric people out there who can explain to me why an infection in the body of the kidney that may or may not be associated with bacteremia is not considered to be a significant disorder. And, why is bacteremia so significant? It's not significant until it lands someplace. Otherwise, in the old days when there was pneumococcal bacteremia and blood cultures were done all the time in febrile kids, they would often come back positive, and you call the kid up and they do another blood culture, and it was cleared. The body cleared it of the bacteremia that you found. So bacteremia seems to be a problem only when it lands someplace. In any case, so we got the modified criteria coming to us, and you have them listed in your book there it turns out the Philadelphia criteria are the best criteria to use. And they've been compared head-to-head, and Philadelphia wins. Having been a graduate of Temple Medical School on Broad Street in Philadelphia, I'm in favor of the Philadelphia criteria as well. Plus, Philadelphia has been known for its quality pediatric work. We had Children's Hospital of Pennsylvania, which was linked up to the University of Pennsylvania, and we had St. Christopher's Hospital. St. Christopher's Hospital, that's where we went. But in any case, low-risk criteria. Now, this is a little tedious. I'll move through it, but I just want to make a comment here and there. A lot of this is kind of like self-explanatory. Well, by definition, the kid has to be over 29 days old. Full term, you bet. No previous visits or hospitalizations for fever. Well, that sounds reasonable. No prior invasive bacterial illness. Okay, all right, that's good. That's good. No prolonged NICU stay. No chronic medical problems. How does a 6 or 8-week-old have chronic medical problems? But anyway, that's on the list. No prior systemic antibiotics. No skin or soft tissue infection. What you have to do here is look carefully around the belly button. Is that infected down there? That is going to be one of the leading causes of no meningitis. No, it's not in the urine. It's not in the bloodstream. It's a cellulitis around the belly button there, omphalitis. They basically said we'd like the white count to be between 5 and 15,000. We'd like the neutrophil the band to neutrophil ratio to be 20% or less. We did an enhanced urine. You know what enhanced urine is? You just take a urine without spinning it down, stick it on a hemocytometer, and then you count the little white cells and/or bacteria, white cells in the hemocytometer chambers. How do you do a plain normal UA? Well, you spin it around in the centrifuge, dump out the stuff at the bottom, and put a slide on top of that, cover on top of that, and you look at how high-powered fields, and you're looking for 5 or more. 5 or more is considered nasty. Now, some people say 10, but most say 5, so stick with 5. Actually, in the low-risk criteria here, they say 10. They say 10. That's what they say. Okay. And the chest x-ray if you think you need it. So that's all the criteria except one. Except one. What is that one? Well-appearing and easily consolable. That requires your judgment. your judgment. So you got to throw your judgments into the equation here. And if in fact you're wrong, and that kid really is not well appearing and easily consolable, then all of this stuff doesn't matter because it doesn't apply. It only applies to well appearing and easily consolable kids. So that requires that you have some experience taking care of 1, 2, 3-month-old kids. And I think that they're getting infections less and less and less. I mean, moms are now surveilled for group B strep, and if it's found, they get antibiotics to clean out their genital tract from that bug, which is kind of a bad boy. And there's herd immunity, so everybody's got the pneumococcal and the HBig vaccine. So those are the kinds of things that make it less common that we see pretty sick kids. After a while, the Philadelphia criteria people said, "Hey, listen, okay, forget it. We're going to pass on the what's called the enhanced UA that I just tell you about, and we're just going to do 5 white cells or less." So that's kind of more common, easily available to everybody. So the first question: how well does the modified Philadelphia criteria work in terms of defining low-risk infants? And to tell you the truth, it works really well. But the paper that we did not cover last year, which is the important paper this year, is a paper by Aronson. It was published in December of 2018. Now, all of these papers have some nice introductions where they give you all of the background information and tell you kind of why we did this study. So by way of background information, they said approximately 10% of febrile infants, 60 days or less, have a serious bacterial illness, 10%. 10% have serious bacterial illness, that's bacteremia or meningitis, 10%. Now that was from 0 to 60. We're only interested in 29 to 60. Now some numbers. 0.2% of febrile children in the second month of life have meningitis. That's 1 in 500. 0.2%, 1 in 500. So in this, according to these people in the introduction to their study, they said you're going to have to do 500 lumbar punctures to find meningitis in a well-appearing child in the second month of life. And you want to do 500 lumbar punctures? Well, good luck. And the other thing is I'm concerned about, honestly, is do our residents that are graduating now have a lot of experience in doing lumbar punctures in 2-month-old kids? I don't know. But I have some doubts about it. But if I'm wrong, you just tell me. If residents get out and they feel comfortable, I'll do it, no sweat, then let me know about it. They said that we would like to back off on the lumbar punctures because it costs too money. Well, that's nominal. Increased hospitalization rates, you bet, because you do a lumbar puncture, you're going to send that kid home? No, you're not. No matter what, that kid's going in the hospital for at least a day. And that there's significant stress for the parents. Well, yeah, I think that's probably true. Maybe if you had just asked them to leave the room and just tell them you're going to extract some brain juice from another kid, things will be okay. But yes, that is an issue. What other things did they say in the preamble of this study? Their overall prevalence of invasive bacterial illness, bacteremia or meningitis, has been reported to be 2% in febrile infants. 2% of febrile infants. Actually, the range is going to be in the neighborhood of 2 to 4%, depending on what study you look at. 0.3 to 0.4, I'm going to stop giving you numbers there. 0.3 to 0.4 of febrile infants will have meningitis. They also point out that, and others have said this too, that these serious conditions are much more common in the neonate, the first 28 days. The graph really says even after the first 3 weeks, things get a lot better. And some of the protocols start looking at age 21 days and go up. So that being the case, We're not going to mess around with our first month treatment, but we sure would like to mess around with the second month treatment. So abstract number one, how well does the modified Philadelphia criteria work in identifying high-risk febrile kids? This is 11 pediatric hospitals, 135 kids this is probably a PECARN study, with all of these ERs that want to contribute, bringing data together. Great idea, whoever thought of it. Was that Dr. PECARN? No, I don't think so. They had 135 cases of well-appearing children who had invasive bacterial illness, 135. Well, I called up the author in this said, did you know anything about the denominator? How many children did you have to see to find 135 that had invasive bacterial illness who were well-appearing? And the calculations that I had by working backward are, you had to see 750 kids to find 135 for this study. So this study it's not a small study. They took the worst kids and piled them together to see what characteristics they had compared to the criteria for the modified Philadelphia criteria. So this is actually a study of 6,750 kids, and they find these subset of 135. Of the 17 cases of meningitis, 7 were over 28 days. So 10 were in the first month of life, 7 were in the second month of life. The modified Philadelphia criteria misclassified 11 kids. So out of all those kids, 135 who had invasive bacterial illness and all the characteristics, the criteria missed 11 of them. Missed 11 out of 135. And they said that basically that these 11 were actually low risk when in fact they weren't. None of them had meningitis. They had, bacteremia, UTI, that kind of thing. But none had meningitis, and that is really important because every study that looks at this, I'm going to talk to you about, yes, their systems are not perfect. They're not perfect, but none of the kids had bacterial meningitis. So the authors here quote, our findings support the use of the modified Philadelphia criteria without routine CSF testing for febrile entrants in the second month of life, quote, unquote. So that's a very direct, non-wishy-washy statement. It says, just follow their criteria. They gave it an illustration using their, some theoretical numbers. So if 300 febrile infants over 28 days who are well-appearing are seen, 300 of them are seen, 6 will have an invasive bacterial illness, 6 out of 300, and 1 of the 6 will be misclassified by the criteria. They would have been said, this is low risk, but they really weren't. And what did they have? They had almost exclusively urinary tract infections because by far the most common cause of a fever in a well-appearing child is a urinary tract infection, otherwise known as pyelonephritis. Now, the Aronson paper, is looking at 60 days or less, but their recommendations are only about the second month of life. I didn't get into the weeds about what they found in the first month of life, but they said, forget it, stick to the criteria for the second month and you'll be fine. Last year we talked about the step-by-step protocol. This is British, 11 British ERs got together. And one of the nicer things about this algorithm is that with regard to a year assessing the kid, they only wanted you to look at 3 things. Appearance of the kid, the work of breathing, that's usually pretty easy to determine, and how was the circulation? Was the kid looking mottled or was the capillary refill decent? That's all they wanted to do. And if you had all those 3 okay, you were in the study. They came up with 2,185 kids from these 11 ERs who were well-appearing below the age of 90 days. So they stretched it out a month. The incidence of serious bacterial illness was 23%. In the prior paper where they talked in the introductions, they said it was 10%. So here's one of the 2 papers that say, no, it's not 10%. Serious bacterial illness is 24%. But you have to remember, this is British. And in Britain, everybody has a doctor. So the threshold for going to the emergency department with a fever may be much, much less. So this may be a clear-cut case of selection bias, because maybe not every febrile kid runs to the emergency department in Britain. In any case, using their step-by-step criteria, only 45% of the kids in the study were determined to be, okay, these are low risk, you can send these kids home. I don't know that that's particularly good. So the results, out of 991 kids thought to have a low risk, actually 7 children had invasive bacterial illness. That's not bad. That's 0.7%, 0.7%. Actually, it's quite good. And you have in your notes there what is the step-by-step criteria. And one of the problems with these studies is meningitis is so uncommon. There were only 10 cases of meningitis in the study of 1,800 kids, 10 cases of meningitis. So it's like, well, that would be, you'd have to do 1 in 180 taps. But again, I think that the population was certainly skewed over there compared to us in the emergency department. So when you only have 10 cases of meningitis, can you say with confidence, what is the confidence interval about meningitis? Well, I'm going to show you that some of these confidence intervals are not so hot. So I'm not going to go through the algorithm. You know, you got it there. They're looking for age. This is, you can see this, age 21 days or older. So this, they're kind of giving you the last week of the first month into your second month. They're looking for what is the urine showing, and are looking for what is the procalcitonin. That's the first one we see with procalcitonin. They also are looking at CRPs or absolute neutrophil count. And they, through this pathway, come up with low-risk kids. So out of their pathway, 991 kids. Now remember, they started altogether with 2,185. So if you got into their protocol, it was a safe protocol to follow. Next concept is the revised concept. So the American Academy of Pediatrics said, listen, we got to narrow the variability that's going on with the treatment of these kids, and that there is substantial over-testing, substantial over-treatment of these kids based on what has been happening in clinical practice and what the literature is saying you ought to be doing. So they had a program, AAP had a program called the Revised Variability in the Infant Sepsis Evaluation. Reduced Variability in the Infant Sepsis Evaluation. It's called REVISE. And the goal was to decrease variability in well-appearing febrile infants. They say, quote, thousands of well-appearing febrile infants, 7 to 60 days old, undergo evaluations for suspected bacterial infection in the United States annually, which often leads to overuse and unnecessary hospitalization, despite the fact that the vast majority of these infants do not have bacterial infections. So they're saying, please, let's get a little literature focused on how these kids are evaluated. So in 2016, based on a review of the literature, the AAP came up with, basically they came up with the Philadelphia criteria, and it's listed for you in your in your notes there. And what they wanted to know is how that algorithm, when they basically told hospitals about it, how did it change behavior? And it's kind of interesting. So this is abstract number 3. It was published in 2019, and it was not random hospitals. There were, how many hospitals were in this? 124 hospitals. Where did these hospitals come from? They were not PCARN hospitals, I don't believe. They were hospitals that were interested in narrowing the variability in pediatric fever. They sought out being in this program. They had to pay $750 to be into this program. And so it ranged, I think, from community hospitals up, but all of them had to have a pediatric hospitalist kind of thing. So that was kind of the minimum. What they did is they created a quote-unquote vigorous change package, which basically was all kinds of things to get the doctors at these hospitals to be aware of the basically the modified Philadelphia algorithm. That's what they wanted them to do. They made it so easy for them that the Children's Hospital, Mercy Hospital, Kansas City, took all of the criteria that they developed and put it into an app. And here's it: you've got to get this app. This app basically will guide you through who's low risk, who's high risk, and what to do. Get the app. It's called PEDS Guide, PEDSGUID. If you put in your internet PEDS Guide, you'll see it on the top, and you'll see PEDS Guide. It's not PEDSGuide.com. So look for PEDS Guide, and you'll find it. University, Kansas City Children's Mercy Hospital. So these 24 hospitals were in 38 states. They looked at 20,570 kids, a lot of kids. And they looked at two outcome measures: the % of hospitalized infants who were evaluated and hospitalized appropriately, i.e. using their protocol. But they were instructed in that protocol big time. And everybody agreed, and there wasn't anybody fussing, no, we're not going to do it kind of thing, because they wanted to be into this survey. And they also looked at the % of hospitalized infants who were discharged with an appropriate length of stay. And here's what they found. When they beat all of the doctors to improve their morale around this program, they evaluated properly evaluated patients went from 75% to 82%. They did all of this work for 7%. And I didn't put in my notes what was the confidence interval here, but I did all of this work to get to 82%. And these are hospitals that are working to try to, and they all agreed on the protocol. It's like, why didn't they do it? And so the second criteria that they were looking for in terms of what they were trying to achieve is the appropriate length of stay. The appropriate length of stay went from 21% got appropriate length of stay to 37%. So it almost doubled, but appropriate length of stay is 20 to 37%. Where's the 80s and 90s%? You have all of these kids getting routine admissions just to cover the doctors, but the fact of the matter is unnecessary. So listen, go get that app. That app, if you get anything out of this lecture, it's get the app. It tells you everything you want to know. What about the effect of these criteria on a single hospital where they are extraordinarily motivated? Now, all those other hospitals are supposed to be motivated too, but how about a single hospital? That's abstract number 4. This is published in March of 2019, pretty current. And their goal, and this coming up study, was a narrow variation and adopt the use of evidence-based guidelines. That's it, okay? This project began in 2015, and they used the modified Rochester criteria, which Philadelphia is better. As an example, I noted here, the modified Rochester criteria has an 83% sensitivity in identifying, low-risk kids. The Philadelphia criteria has a 92% sensitivity in identifying low-risk kids. So what they did in this study, they had 350 kids at their one hospital, febrile kids. Over a 3-year period, 220 kids were seen before they initiated protocol, and then 130 were seen after they initiated the protocol. The protocol, of course, was, heavy instruction, electric shocks, beatings, reduce their salary, whatever it took for them to get with the program. And the results are truly unbelievable. And they're so kind of make you feel good about what you can do if you really want to. LPs decreased from 32% to 0% in all of these low-risk kids. Antibiotics went from 30% to 1%. Hospital admissions went from 17 to 2%. Post-implementation, there were no serious bacterial illnesses, pyelo, bacteremia, meningitis, found in low-risk infants versus 29% in high-risk infants. Well, there's a high number, and this is an American study. So I can't account for it now because we had 10%, then we had the British that said 24%, and here we have 29%. In high-risk kids. Okay, so that's, I think the results are truly remarkable. It really, whoever did this, guys, you're Dr. Casimir and colleagues, you're to be given an attaboy. And in your notes, we have this great outline. This is all you ever need to know about pediatric fever. This is it. And it's put into a computer, basically, by the people from Kansas. But now let's get to the real heart of the matter. Wouldn't it be great if there was a protocol that it didn't matter what the kid looked like? It didn't matter. So you didn't have to use your physical judgment. Is this kid well appearing and not well appearing? None of that would matter. It's just strictly dependent on tests. You could have the nurse order tests when they came in, and if the tests are negative, they could send them out from the triage area. Not really, but this would be heaven. Well, abstract number 5 is about heaven. This came out in 2019. It's from the Pecan group. The head of the lead author was Nate Cooperman, and I got to give a shout out to this guy. 2019 was a really good year for him. He had 2 major papers, this being one of them. He's at UC Davis, and I want to say, Dr. Cooperman, I have always had the highest regard for you since I've known of you for many, many, many years. So he's in charge of UC Davis, and I had to acknowledge that Martha Roberts, the daughter of Jim Roberts of Roberts and Hedges, right, the big book of procedures, is now working there as a frontline nurse practitioner, and you will not find a more competent nurse practitioner than this woman. She is incredible how much postgraduate training and experience that she's had. In any case, we're moving on. So they, in this study from Pecan, they got data on 950 febrile children, 60 days of age or less. And the data was put into a computer, and the computer is asked, find us all of the kids who, if they have all the kids who are low risk by objective test criteria, no physical exam. We're going to get tests only. And obviously a computer could do that. It could just find out the criteria. They put all of them in, and it sorted and sliced and diced, and there it was. So they did so that was the group where they developed the criteria, and then they had another group of 900 and some kids who where the criteria were applied. So that was prospective group, the retrospective group, prospective group. The criteria were applied, and you will not believe this. Yeah, there were a few kids excluded. I got to tell you, look critically ill, antibiotics in the prior 48 hours, history of prematurity, indwelling devices, pre-existing medical conditions, no soft tissue infections. You got none of those, that's it. We don't care whether the kid is sick looking or not. Now, to find out what was the cause of fever in these well-appearing children, or any kind of a children, they excluded kids. No, actually they didn't. They included kids who had otitis media. Why? Because otitis media doesn't have cause a fever. And if otitis media doesn't cause a fever, then there must be some other cause. And so those kids can go into a study where we're looking for what that cause is. And this goes along with the paper that I did where I showed you 8 other studies. I stopped at 8 that had kids who had otitis media included in, let's find the source, because it's unknown. We don't know what it is. Because otitis media doesn't cause a fever. In any case, what were their results? Their 3 criteria, which I'll give you in a second, had a sensitivity of 98% in finding who is low risk and who is high risk. So they missed 2%. 1 infant with bacteremia was missed, as were 2 UTIs. No meningitis was missed. There were only 10 cases of meningitis in the entire study. This is like the other one. They only had 10 meningitis cases as well. So does this study really have the power to exclude the most serious of the serious bacterial illnesses? That's the issue here. What were the 3 negatives? Negative UA. That's easy to do. Send it over to lab, they'll tell you the answer. And we're going to talk more about that in another talk about how important nitrates are, et cetera, et cetera. An absolute neutrophil count of 4,090. And it was 4,090 because it was derived by a computer. So a computer doesn't want to round off. Here's the numbers, 4,090, absolute neutrophil count. And a serum procalcitonin of 1.17 nanograms per ml or less. And if you had all three of those, then according to this, you were low risk and you can go home. The problem is they only had 10 cases of meningitis. And it was done by the Pecan group in terms of getting the 900 that they developed the criteria on, and another 900 that they tested criteria on. And they said, not good enough, not good enough. We want you to have this validated in another group. Well, what other group is going to do it? Pecan's got like 28 hospitals. You're gonna have Pecan validate itself? Well, maybe, or send it over to Europe where they get these 11 hospitals that are into it. But we got to get the answer to this pronto, quico, because three things: low risk from high risk, no lumbar puncture. If this turns out to be the case, and Dr. Cooperman, being the scientist that he is, said, "Listen, you cannot do this just yet. We need external validation." I think it's going to be really, really pretty big. Okay, so that is enough of this. I think that the issues are pretty clear. We're looking for the kid who has meningitis who looks well, and we're looking for criteria to screen high risk from low risk kids, and there are good criteria out there for screening high risk from low risk kids. Never say never, maybe, and some of these criteria missed serious bacterial illness, but they did not miss meningitis, although there are only 10 cases in some of these studies. So please consider looking at that nice graph and chart. Embrace that. Get that app, and I think your life with regards to treating kids should change substantially. Thanks for listening. Bye for now.